Shall we start again?
Yes, sir. Start, sir.
Good evening to everybody. On behalf of IAP TNC, I welcome one and all for this postgraduate case presentation by IAP Tamil Nadu. Now I request our Professor Dr. Gopal Subramaniam to tell that pediatrician prayer.
Good evening, one and all. We'll start today's program with the pediatrician's prayer. குழந்தை மடத்தனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவரது குடும்பத்தினருக்கும் அவர்களின் சமுதாய பிரிவினரை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் ஈகை அன்பு அமைதி ஆகியவற்றின் தூதரலாக என்றும் இருப்போமாக நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்தையும் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களையும் கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now I request our dynamic president, Dr. Ramesh Babu, to deliver a presidential address.
Thank you, Dr. Rajendran, sir. Respected Treasurer Dr. Gopal Subramaniam and respected Secretary Dr. Rajendran, sir. Respected office bearers of IAP PNSC, Editor Dakshayani Madam and AAA Dr. Tirumurugan, sir. And respected judges of this program, Dr. Srinivasan sir, Dr. Rama Madam, Ramesh sir, Janani Madam, and Ramesh sir from Chidambaram, and respected chairperson of today's event, Dr. Sasidharan sir, respected moderators, Dr. Mullai Balaji and Dr. Renu Madam, and respected delegates and my dear postgraduate students attending all over the state and from other states too, through various channels. I thank our dynamic secretary, Dr. Rajendran, for continuously and successfully conducting this PG teaching program. Today's topic is on acute headache with Diplopia. The presenters from KMCH. At this juncture, I take this as an opportunity to request all the students that we have IAP PNSC has started a membership drive from Monday onwards, from 4th of July to 11th, so that we have to improve our membership strength, both for the students for become an associate life member and for the pediatricians who have already completed their degree course, but yet to become member. I request them to become life members of our organization so that we can improve our membership strength. I appeal to all the faculties to motivate their postgraduates and as well as their fellow pediatricians who are not yet members to become members. I wish this teaching program a great success. In this short note, I thank once again Dr. Rajendran for successfully carrying out the proceedings. Over to Dr. Rajendran. Thank you.
Thank you, Dr. Ramesh Babu. Respected our President, Dr. Ramesh Babu, the President-elect, Dr. Suresh Balan, and President 2021, Dr. Ismail, the Vice President, Dr. Annamalai Vijayaraghavan, sir, and Joint Secretary, Dr. J. Balasubramaniam, and AAA, Dr. Tirumurugan Sarani, Editor, Dr. Dashani, all central as well as state EB members. And on behalf of IAP TNC, I welcome all the IAPians. And first of all, I welcome our chairperson, Dr. Sasidharan Kandasamy. He is currently a consultant pediatric intensivist at Mehta Children's Hospital in Chennai. And he is a PGA alumni. I welcome Dr. Sasidharan. I welcome today's moderators, Dr. Mullai Balaji. He is currently a consultant pediatric intensivist, Kobe Medical Center and Hospital, Coimbatore. I welcome Dr. Mullai. I welcome Dr. Renu Sudhar. He is Associate Professor of Pediatric Neurology Unit, Advanced Postgraduate Institute, the PGI Chandigarh. I welcome Dr. Renu. I welcome all the students from Kobe Medical Center and Hospital, Dr. Lakshmi Sasikan, Dr. Salima, Dr. Kritika Sivaraja for the case presentation. I welcome my colleague and my friend Dr. Aswath D. Turaisamy for this program. I welcome all the judges, Dr. Janani Shankar, Dr. P. Ramchandran sir, Dr. S. Ramesh, Dr. Rama Chandra Mohan, Dr. Srinivasan sir from Pondicherry. I welcome all the students from all over India as well as our faculties. On behalf of IIP TNSC, I welcome one another. Thank you. Now it's over to Dr. Sasidhar.
Thank you, sir. Thank you for the warm greetings. From the team for today's program, I am extremely happy to be part of the program. And we have moderators, Dr. Mullai Balaji, who is a pediatric intensivist at KMCH, as well Dr. Renu, who is a pediatric neurologist from PGI. So this is the best team to discuss about acute headache with diplopia. Thanks for selecting such a appropriate topic, sir. And with this, I hand over to the presenting team. So you can proceed with your presentation.
Anand?
Rashmi, please proceed.
Start.
Good evening, one and all respected teachers. Today I'm going to present the case of acute headache with diplopia.
Anand?
Yeah, please, Aswat Pas, please. Hello? Yeah. Yeah, proceed. Yeah, Lakshmi, proceed.
Good evening, one and all. I'm Dr. Lakshmi, and I'm presenting the case of acute headache with diplopia. So, Ms. Jane, who's a 10-year-old girl born to non-consanguineous parents from Coimbatore, the informant of her history was her mother, and the reliability was good. She's right-handed. She presented with chief complaints of neck pain, back pains in 6 days, along with headache and deviation of both eyes with blurring of vision since 3 days. Coming to the history of her presenting illness, she's an apparently normal school-going child studying in grade 6 who was on a vacation with her family in Kerala 7 days back. And next day morning of her travel, she suddenly developed severe neck pain and back pain. It was sudden in onset, progressive in nature, and severe in intensity, not radiating to arms or legs. By evening, she also developed unbearable headache, which was throbbing type, severe in intensity, felt all over the head throughout the day, and it was aggravated by change in position and straining, and it was felt worse in the morning. It was not relieved by rest or sleep, and the headache did not abate with medications. She was very irritable and preferred to stay in dark and quiet environment. It was also associated with multiple episodes of vomiting, which was non-bilious and non-blood state, not associated with nausea or food intake. She was consulted in a local hospital at Kerala and was treated symptomatically. Her vomiting was subsided after 1 day of treatment, but all the other symptoms persisted with the same severity, and they came back to Coimbatore for further management, and she got admitted in a nearby hospital. From day 3 of illness, she gradually developed blurring of vision along with double vision. Her mother also noticed deviation of both of her eyes. She had difficulty in reading and focusing on objects, but she was able to distinguish between colors. Her double vision was more pronounced by looking sideways. Her routine activities and sleep was disturbed, and later on she was even unable to sit and walk due to severe neck pain. There is no history of any fever, loose stools, cough, cold, rashes, no history of any ear or dental infections, no history of any abnormal movements in the form of convulsions, there is no weakness of limbs, no altered behavior, no hallucinations, loss of consciousness or giddiness. There is no history of recent fall or trauma, and no history of weight gain or weight loss. There is no involvement of other cranial nerves, and there was no loss of smell or altered smell sensation. There was no drooping of eyelids. There was no difficulty in chewing. There was sense of taste was intact. There was no deviation of angle of mouth or drooling of saliva from the mouth. Hearing loss was not present. There was no vertigo, tinnitus, nasal regurgitation, dysphagia, hoarseness of voice, or dysarthria. She was also able to feel her clothes, perceive touch, and appreciate pain and differentiate between hot and cold objects. There is no tingling sensation or numbness, and no bowel or bladder incontinence. She was investigated and treated in the nearby hospital with symptomatic drugs, and the symptoms persisted with the same intensity, and she continued to be irritable with severe headache and backache. And thus, she was referred to our hospital on day 7 of illness, where she was admitted in our ICU. Coming to the past history, she did not have any episode of similar illness in the past, and there is a history of vitiligo for which she was treated with some natural medicines for around 1 year, and she stopped it 10 months back. 1 month ago, she also took treatment for head lice infestation using permethrin shampoo. There is no history of other chronic drug intake, no history of seizures, hypertension, or cardiovascular disorders or any bleeding disorders. She is not having any contact with TB patients. No recent vaccinations were taken. No history of any viral exanthematous fever or dog bite, and her behavior did not show any recent change or decrease in scholastic performance. Coming to her birth history, her mother was a second gravida, booked pregnancy, and conceived at the age of 27. She did not have any medical illness, and all her antenatal scans were said to be normal. She was born at 38 weeks via normal vaginal delivery, and her birth weight was 2.8 kgs. And she cried immediately at birth, and no neonatal concerns were present. Her developmental history was appropriate, and she achieved all milestones at age. There was no developmental delay, and currently she's studying in grade 6 and has good scholastic performance. She's active in her extracurricular activities as well. She consumes a mixed diet and has a good appetite. She's not on any nutritional supplements. There is a history of intake of raw milk. She gets a calorie of 1,750 per day and a protein of 40 grams per day. And there is a 50 kilocalorie deficit and 5 kilograms per day excess of proteins. She's immunized as per the IAP schedule, and but the 10-year vaccine is pending. BCG scar was present, and last vaccination was taken at 5 years. Coming to her family history, she's second born to non-consanguineous parents. There is no family history of migraine, seizure disorder, coronary artery disease, hypertension, or any cerebrovascular accidents in family. No bleeding disorders in family. No person has TB, and other family members did not have any similar symptoms like personal history. She has regular bowel and bladder habits. She hasn't attained menarche yet. No history of any known allergens or allergic to medications. She also has 3 pet cats at home. Coming to the socioeconomic history, her father is a graduate and an engineer, and their monthly income is around 50,000. And as per modified Kupasamy socioeconomic status scale 2021, she belongs to upper middle class socioeconomic class. So to summarize the history, she's a 10-year-old previously well school-going child, born to non-consanguineous parents, immunized up to age, with history of vitiligo and no other significant past history or family history, now presenting with acute onset of severe neck pain, backache and headache with photophobia for the last 6 days, initially associated with vomiting, followed by visual disturbances, diplopia and squint for the last 2 days, and symptoms not relieved by medications. So, if you miss it,
Dr. Lakshmi, once again, yeah. So, I'll just interrupt now. There were a few questions which are put up in the chat box. So, was the vomiting projectile? Like, how did they describe the vomiting? And what is the significance for that?
Initially, the vomiting was projectile, sir.
Okay.
Projectile, vomiting can indicate raised ICP.
No, I mean, what do you mean by projectile vomiting? And for the benefit of PGs, so other PGs are also listening. So, why do you ask such a history? And what do you mean by projectile vomiting? First question. Second thing is, why is it important?
In projectile vomiting, there won't be an association with nausea, and the child will have a sudden urge of vomiting.
Okay. What is the relevance for that?
It can be seen in conditions like raised ICP. It can be also seen in acute intestinal obstruction.
Okay. And you are talking about some development of double vision. So where the parents or was the child able to tell exactly when did she have double vision? Is there? Can you elaborate on that?
She told like she was not able to see clearly, and she's having a double vision, especially while looking sideways. So she preferred to look front most of the time. And there was no diurnal variation of diplopia. It was present throughout the day.
Okay, I think Dr. Renu ma'am had something to.
Yeah, Dr. Lakshmi, I have a couple of questions for you to elaborate upon. So when we have a child with headache, we try to differentiate in the history regarding is it a primary headache or is it a secondary headache. So for that pattern, a detailed headache history is warranted. So I want to know from you regarding headache. So what do you think the pattern was? Localization was the pattern? You said she has a throbbing kind of headache. Was there a pattern with crescendo and decrescendo pattern? Was there any periods when she did not had headaches? What was the relation of headache with the sleep? Did it disturb her sleep also? How severe it was? How did she rate this headache? And that she has any aggravating or relieving factor? You said that she would prefer to lie in a dark place. Okay. So was the associated photophobia, was it aggravated with some sounds? So when we take history, we try to differentiate it from primary headache versus a secondary headache. Since it was a first episode in this child, which was quite severe, so we should be also thinking whether she has previous similar kind of episodes which are minor, which were neglected. So I want to have your views on these symptoms. And regarding aura also, you did not talk about any aura in this child preceding the headache. Was there any associated visual symptoms? And now the second question is, after this headache, you should also describe detail about vision loss in this child. So was it a persistent vision loss, or she was more disturbed with diplopia?
You probably go back to the,
yeah.
Sorry, you can go back to the history slide so that, sorry to interrupt.
So, so I'll come back to vision. What I want to know about vision, whether it was more diplopia or it was more vision loss. Did she has problem with the with monocular vision also? Did she had difference with the color vision also, near vision, distance vision? Did she had this some kind of floaters in front of eye, or do you think it was more related to her visual field defect that she could not see on the one side of eye or one side of the field or second side of field? So I want your elaboration on these points, and then subsequently we can go about etiological history. But before that, we need to know about what are we dealing with. Do you think it is a primary headache which is severe, or do you think it is a secondary headache in this child with the where you need to, what are the red flag signs in this case, do you think?
Ma'am, she presented with a severe type of headache, and she was telling like she never experienced such a bad type of headache, which was throbbing in type, and it was not associated with any aura, ma'am. And there were no other signs like she was able to, she mainly complained of blurred vision, ma'am, and there was no difficulty in appreciating colors, and her diplopia was more prominent while looking sideways. And
was there a pattern in the headache? It was a throbbing headache. What was the pattern? It was frontal, it was occipital, holocranial, or what was the pattern? 24 hours it remains same, or there was some periods when the headache was less, some periods was there but it was more severe? What was the relation with vomiting?
Ma'am, initially she had a severe headache, and it was it was not relieved by any rest or sleep, and in fact it was more worse in the morning, and even while moving her head and while straining for stools and all, she felt the headache was getting more severe, and she was a bit relieved after vomiting, but it was vomiting was mainly present only in the first 1 and 2 days, ma'am. After that, vomiting was not there.
Okay, any history of phonophobia along with this photophobia?
Photophobia, she did not like bright lights or being shined or any bright lights in her room, and she did not want any loud noises in the room also. So yeah, there was history of photophobia and phonophobia.
Okay, so what are the red flag signs in this history of headache?
The intensity of pain, ma'am, it was very severe, and it was not relieved by any rest or sleep, and it was associated with vision loss and diplopia. Along
Okay,
with
in addition to that, you have a headache which worsens with the straining cough that suggests a Valsalva, which can aggravate in headache. That is not a typical feature of a primary headache, but it is a typical feature of a secondary headache. Okay. Okay, so now regarding the negative history. Okay, so do you think this travel to Kerala was important in this case? Does it had any relation with the headache?
Yes, ma'am. Actually, after the 1 day of travel, only she experienced these symptoms, and before that she was apparently all right only, and 1 day after traveling only she developed these symptoms, ma'am. So there may
Okay,
be
so some local epidemiological risk factor may be there, that she has recently traveled and she has got exposure to a particular virus or parasite or any kind of infective kind of granuloma, but it doesn't happen within 1 day, but a recent travel is important in these kind of cases. Okay, so okay, so if you think it was a secondary headache, what important history you want to know, that what are the serious causes I want to look into?
there is no history of fever, ma'am, and there is no history of trauma also. And there is no history of any weakness or involvement of other cranial nerves. There is no tinnitus. And there is no exposure to any toxins. So secondary headache can be unlikely.
Okay, Dr. Balaji, you can take further.
Somebody has headache with fever. So what are the possibilities that you'll consider? You said no history of fever. So somebody says that I have fever and also I have a headache.
Yes, sir.
Yeah.
Mainly we can think about meningitis or any intracranial infections or any ear infections, dental infections, which can be associated with fever and headache.
Okay. What are the thing in the head and neck region that you will consider? One you said is ear infection,
abscess,
dental, odontogenic.
pharyngeal abscess, brain abscess, sinusitis.
Yeah, sinusitis is again one more. I mean, these are some of the common presentations with which they come to the OPD or even to the emergency department. So in sinusitis, like what history you will specifically ask for? If somebody you think it is something very simple like a sinusitis presentation, what are the history?
Of nasal blocks, sir, and recurrent infections, and there will be history of allergy, and mostly the headache will be there depending on the sinus which is more affected, like while stooping forward. Then there will be also facial pain associated.
Okay.
There can be tenderness on palpation of sinuses.
Okay, so Dr. Lakshmi, can you what I understand from history is afebrile. She remained afebrile throughout this 7 days of presentation. So afebrile patient who presents to you with headache. does the timeline gives you clue that what kind of etiology we can have in this patient? So how do you divide the timeline of headache in these patients, and how does the timelines help you in ascertaining etiologies?
Ma'am, it can be acute headaches are mostly seen in viral infections, sinusitis, dental infections, meningitis, and polyphasic headaches like cluster headache, tension headaches can be also present acutely, ma'am. Migraine can also present as acute headache, but usually they'll be having previous history of headaches and all. If it is if there is history of chronic headache, then we can consider other causes like tumor, hypertension, medications.
Excuse me, dear panelists, please ask questions to Dr. Salima and as well as Kritika also there, other two PGs, please.
I think so. Let us involve the other PGs also. I have few questions. Dr. Lakshmi, are you physically involved in managing this patient? Are you involved in managing? You were part of the team who have managed this patient?
Yes, sir.
Okay, so then you would be able to be comfortable to answer few of the questions. Routinely in past history, you have told 1 day travel to Kerala. Okay, so it's only 1 day travel, is it right?
Yeah.
Stayed for 1 day. Yeah.
Yes, sir. They could really stay for 1 day, sir.
Okay. So any like they have gone and they stayed for 1 day. What was the exposure kind? Like they have stayed in some stay home, or they visited some friends. Whether there is any swimming pool or any kind of unusual activity, trekking, anything like that? Nothing.
Actually, she went to Alapura, sir, but there was. She told like she did not go into the water bodies.
Okay. So and other PG can like who else is there with you?
Yeah, Dr. Salima is there. Dr. Kritika is there.
Yeah, maybe Dr. Salima can take this question. There was a past history. She told very clearly about vitiligo, and there was a treatment taken for vitiligo. By the chronology, 1 year prior to the this episode of admission, child had symptoms of vitiligo and they have taken Ayurvedic medications. And 6 months back, they stopped the medication. Isn't right?
10 months back. 10 months back, they stopped the medication, sir.
3 months back. Okay. So on what basis this history becomes important? And do you want to give some more information on this history?
The drug intake, any chronic medications can cause raised intracranial pressure, and it can lead to headaches, sir.
Okay, medication exposure, whether it is causing a toxic encephalopathy, that's one possibility. And there is no acute exposure. It has already been stopped 3 months back. Yeah, so there is some kind of a withdrawal. A component is causing a withdrawal, causing a raised ICP. Okay, that is also possible. Anything else?
Vitiligo is an autoimmune condition.
Okay. So I hope you would be able to describe us more during your examination. Is it right?
Yes, sir.
Okay. Can we go further?
Yes,
can we go further? Or
yes, sir. Just a couple more. Just expanding on vitiligo, any other thought process? Somebody has vitiligo, somebody presents with headache.
Yes, sir. Since there is one autoimmune condition, there are chances of other autoimmune.
No, you told about autoimmune, that is fine. And they told about medications, they are fine. I'm asking, apart from these two connections, can you just expand it further? Dr. Salima can.
Any medications are
other postgraduates can contribute. Yeah.
Okay, somebody, an adolescent girl, 10 years girl has vitiligo. How would she feel? What will be her self-esteem? how would she feel when she goes to the school, her peers?
Depression and
So does that have anything to do with the presenting symptom that she has?
Yes, sir.
Can be a somatic symptom for a depressive disorder, though it may not be so severe and so acute in onset. So we should also think whenever they have some skin conditions like these, it could be possible that they have some somatic manifestation due to the peers who can just bully them that they have these skin conditions. They have their own self-esteem gets a hit. So that is something that we should also keep in the mind when we have such dermatological conditions. And there were again a couple more questions in the chat box. Can you, Dr. Kritika, can you please explain regarding the dietary history relevance in the current case?
Dietary history, she had only history of raw milk intake, sir. Other than that,
your voice is breaking.
okay, sir.
It's echoing a bit.
So she had history of raw milk intake only. Other than that, no significant history was present, sir.
No, what specific dietary history would you want to inquire in a kid presenting with such a, such a presentation?
Pig or any meat intake. Since you have traveled to Kerala, any raw pig, something like that, sir?
No, related to what problem? You're saying about raw meat or something. It
yes,
causes
sir.
what?
Cystic fibrosis like conditions can also be taught, sir, but
when you put forth your answers, you just try to be little bit in track with the chronology of symptoms. Basically, whenever a person has a new onset symptom, immediately after a travel, always we have a suspicion about the travel, whether it is 1 day or 2 day or whatever may be. So two things come to our mind. Common concept is whether it is any unusual activity. Okay, unusual activity starting from food habits and trekking or going to the exploratory travel, going to some place. This are all not uncommon nowadays. And swimming, exploring in like a pond, all these things are common. So those things all put together, as Dr. Renu has told, is there any epidemiological conglomeration of infective diseases in that part of the area where they visited? So that much it becomes relevant. Food history, obviously food history has a continuation to infective exposure. But when you see cystic psychosis and all, it doesn't happen with a, like one day you haven't eaten meat and next day you present with the symptom. That is not the way. So when you put possible etiological factors, when you are putting a correlation list, you just make sure that your chronology of symptoms and presentation is fitting in. Okay, so this is from my side, and I think there is another very important question in the chat box. You are telling vitiligo, so obviously people have started thinking laterally whether there are any neurocutaneous markers. Have you specifically looked at for it? That's what I told. Vitiligo means in physical examination you are going to explain. So if you have anything to explain in the physical examination, we can take up this question later. Can we take this up later during the examination? Yeah, so you can proceed with your presentation. Yeah.
I have one more comment
yes,
or suggestion here. So this history of vitiligo becomes extremely important in this girl. And so what are the common drugs which are implicated with in a girl who develops a vitiligo? What are the common natural or Ayurveda or other allopathic medications commonly used by adolescent girls which are implicated in creation of raised ICP, if you think? And what is your explanation for neck and back pain in this child? These two questions are there.
Ma'am, vitiligo can be treated using steroids and retinoids and all, ma'am. And if they're not used appropriately, it can lead to toxicity. And neck pain and back pain. She had a severe neck pain and back pain, and it can be attributed to the neck stiffness, ma'am, which is seen in meningeal irritation.
Okay. So topical steroids, sometimes antibiotics like doxy, mino, azithromycins, topical use of these antibiotics, vitamin A products like isotretinoin, retinoic acids, and these are the drugs which are commonly used by adolescent girl, and sometimes they used large quantities of vitamin A to treat these skin conditions like acne, pimples. So that is one more reason for sudden withdrawal, as well as creation of these symptoms of raised ICP in these girls. So that history becomes very important, and possibly this is because of the neck and back pain is because of root inflammation or possibly irritation to the nerve roots within the lower part of the brainstem or in the cord. That is the explanation possibly for severe back and neck pain in this girl. And one more question: what does she has? 3 cats at home?
Yes, ma'am.
Okay. Do you think this is a significant history?
Yes, ma'am. It can be significant, ma'am, because cat scratch disease can all caused by Bartonella can also produce such symptoms rarely.
Okay.
Another thing about vitiligo, tacrolimus ointment application is not at all uncommon. TAC is very, very common. And most of the preparations of Ayurvedic medications, I do not know what is the preparation ingredient changes from place to place. If you get from the Siddha place where Ayurveda is also practiced, the ingredients will be different. If you get from typical Kerala Ayurvedic preparations, the ingredient may be different. There are ingredients, steroid, everyone of you know. Apart from that, cyclosporin, TAC at low doses can be ingredient of Ayurvedic preparations also. It's not only heavy metals will be there in Ayurvedic preparations. Some of the most of the Ayurvedic preparations, which is our Tamil Nadu based, they won't have heavy metals. Okay, so basically immunosuppressants in different quantities are very common ingredient. And apart from that, when you say like the girl has that and treated for 6 months using Ayurvedic medications, it's absolutely fine. But usually as a parent, how they explore, first they go to a allopathic doctor, they will take some medication, they will take it for some time, and then they will explore alternative medicine, they will take some medication. So the co-medication, the co-consumption of medications, allopathic and Ayurvedic, this also very common pattern. So these patterns are very, very common. First, you should know these patterns are common. Then only you would be able to ask such questions. Okay. For all these history, you have to put forth leading questions. Before Ayurvedic medication started, how long you have been taking allopathic medications? After starting Ayurvedic medications, have you co-administered allopathic medication or not? So all these are pertinent questions. You will get answer only if you ask in this way. Okay. Can we go ahead?
Yes.
Yeah.
So the differential diagnosis at this point of time are intracranial space-occupying lesions, vascular causes like cerebral sinus venous thrombosis, inflammatory conditions like acute disseminated enterocolitis or neuromyelitis optica. Coming to the examination, on general physical examination, she was conscious but irritable. She prefers lying down in a lateral position with her eyes closed, neck extended, and her lower limbs flexed. There was no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Her head shape was normal. There was no micro or macrocephaly. She had lice infestation over her hair. and her eyes showed bilateral convergent squint. Oral cavity was normal and there was no dental caries. Neck stiffness was present, and trunk also revealed multiple hypopigmented patches of vitiligo. It was also present in over her inguinal area. Other extremities were normal, and the back and spine looked normal, and there are no other neurocutaneous markers that were seen. Coming to her vitals, she was afebrile. Her pulse rate was 50 per minute, which was regular, normal in volume and character. All her peripheral pulses were felt equally. Saturation was 99% in room air. Her respiratory rate was 20 per minute. Her BP was 110/70 millimeters of mercury in right thumb and supine position, which falls in between the 50th and 90th centile. Her capillary refill time was less than 3 seconds. Coming to anthropometry, her weight was 35 kg and height was 140 centimeter, which falls in between 50th to 75th centile. Her BMI was 17.86, which is in between 50th to overweight centile, and her head circumference was 52 centimeter, and her sexual maturity rating was stage 2, according to Tanner stage. Coming to the central nervous system examination, first the higher mental functions. She was conscious and oriented to time, place, and person. She was irritable, and her intelligence was normal. Her memory was intact. There were no delusions or hallucinations. Her speech was also normal, and her sleep was disturbed. Cranial nerve examination, olfactory nerve was normal. Optical examination, visual acuity, finger counting was present at 6 meters in both the eyes, and her near vision was blurred. The field of vision could not be assessed. Her color vision was normal, and her fundus also showed papilledema. Her direct and consensual reflexes were normal. Coming to oculomotor, trochlear, and abducens nerve examination, extraocular movements revealed impaired abduction, which was suggestive of lateral rectus palsy. Her pupils were equal in size. Her reflexes were normal. That is, direct consensual accommodation reflexes were present. There was no ptosis. Trigeminal nerve examination was normal. The sensation over face and buccal mucosa was normal. Clenching of teeth and chewing movements were normal. Corneal and conjunctival reflexes were present, and jaw reflex was normal. Facial nerve examination revealed normal wrinkling of forehead. She was able to close her eyes. Her smile was normal. Blowing of cheeks was normal. The nasolabial folds were equal on both the sides. Taste on the anterior two-thirds of the tongue was normal, and corneal and conjunctival reflexes were normal on both the sides. Eighth nerve, Raynaud's test was positive on both the sides, and Weber's test was normal. Ninth and 10th nerve, uvula was central. Her posterior taste sensation was not examined. Gag reflex was present. There was no drooping of shoulder, and shrugging of shoulder against resistance was normal. Flexion of neck and turning head to both sides were present, though she had pain while eliciting them. Hypoglossal nerve was normal, as there was no deviation of tongue or no tongue fasciculations. Coming to motor system examination, bulk was normal, and there was no discrepancy in lengths. Her tone was normal in both upper limb and lower limb on both right and left sides. Her power was best appreciated power was grade 4/5 in both upper limb and lower limb and on right and left. Superficial reflexes, corneal, conjunctival, pharyngeal, and abdominal reflexes were present. Plantar was flexor bilaterally. Jaw jerk, biceps, triceps, supinator, knee jerk, and ankle jerk were elicited normally. The gait could not be assessed, and she did not have any involuntary movements in the form of chorea. There was the sensory system examination was also normal. She was able to appreciate superficial sensations like crude touch, pain, and temperature, and deep sensations like pressure, pain, and vibration and joints. Cortical sensations were intact, namely the tactile localization, 2-point discrimination, stereognosis, and graphesthesia. Romberg sign was not examined. There were no cerebellar signs, no diadochokinesia, no intentional tremors, no nystagmus was present. Speech was normal, finger nose test was normal, and Healy test was not examined. The meningeal signs were present, neck stiffness was present, Koenig signs was positive, and Brudzinski neck sign and leg sign were positive. Skull on examination was normal, and there was no spinal tenderness. Coming to examination of respiratory system, bilateral equientry was erentry was equal, and normal vesicular breath sounds. There were no added sounds. Cardiovascular examination revealed apical impulse on the left fifth intercostal space. On auscultation, first heart sound and second heart sounds were normal, and there were no cardiac murmurs. Abdomen was soft and non-tender. There were no dilated veins, and the external genitalia was also normal. It was there was no organomegaly appreciated. So to summarize the history and examination finding, this is a 10-year-old previously well school-going child, born to non-consanguineous parents, immunized up to age, with history of vitiligo and no other significant past or family history, now presenting to us with acute onset of severe neck pain, backache and headache with photophobia for the last 6 days, initially associated with vomiting, which was followed by visual disturbances, diplopia and spleen for the last 2 days, and symptoms not relieved by medications, and examination revealing bradycardia, papilledema, and bilateral lateral rectus palsy, and signs of meningeal irritation. So we can infer that this is an acute progressive neurological disease with localization in the central nervous system with features of raised intracranial pressure and meningeal irritation.
Mulay, can we pause here and take up questions? Yeah.
Before me, actually, there were a few things in the chat box as well. Dr. Kritika, there's a question like, even before examination, based on the history that she presented, Dr. Lakshmi presented, can we rule out infections such as orbital cellulitis? Or what will be the specific history that you will be wanting to inquire when you suspect orbital cellulitis in a kid?
So when we are suspecting orbital cellulitis, the child will be having painful eye movements. Eye movements will be very painful.
Okay, were they present in this index child?
No, sir. The eye movements are not painful in this child.
Okay, okay. So again, I think there was another question like where eye movements are not painful. And in examination, you had told about convergent squint and limitation of abduction. So were you able to observe when you attempted abduction, was there any nystagmus or anything?
No, sir. There was no nystagmus.
Okay. Yeah, Shashi sir.
What is the significance? If there is a nystagmus of the abducting eye, we are doing.
Yes, sir. If there is nystagmus, we should consider cerebellar involvement. Hello.
No, nystagmus is cerebellar, okay, but when specifically there is a paralysis of this thing, abduction or adduction, and then you find that there is nystagmus of the opposite side. So what will you think of? Which area is specifically involved? Have you heard of internuclear ophthalmoplegia?
Yes, sir. When there is
there can be a very specific lesion due to vasculitis, etc. That's why I specifically asked, because we have shown this thing, squint. But of course, you have to do on both sides and then see whether there is internuclear nystagmus of the abducting or this thing. That has a very specific localizing point. Am I correct, Dr. Renu Satwar? I want your comment.
Absolutely agree with you, sir. Abducting eye nystagmus suggestive of 1.5 syndrome with the paralysis of abduction. So this has to be asked for. So that has a localizing value to MLF basically. So that directly takes you to the pontine lesion. There may be some SOL or infarct or demyelination to that particular area.
Yeah, especially myelination disorder and also in vasculitis, specific
Right,
area
right.
of vasculitis.
Yeah. So, Kritika, I have 1 or 2 questions for you during examination. First is regarding, you did not talk about anything regarding field of vision in this child. At least confrontation you all should always do. Second point is, what about gaze in this child? Was the gaze to up, down, left and right was affected? This was paralytic squint according to you.
Yes, ma'am.
Yeah, so in addition to paralytic squint, you should also ask for a gaze in up direction as well as down direction, because that is a specific localizing value. Third point is regarding nystagmus, as sir has asked. In addition to nystagmus on adduction, sometimes you can have nystagmus in primary gaze as well as convergence. That has a specific localizing value, as we see sometime in Parinod syndrome, where there you have limitation in up gaze as well as you have a convergence nystagmus. So that leads to you a lesion in the upper part of pons, rectum area. So a penile lesion which can cause hydrocephalus, midline lesion can has no other symptoms and no other cranial nerve palsy. So that will just come with raised ICP, papilledema, and sometime limitation in the gaze. Now, fourth point is, you said OFC was 52 centimeters. I also want to know, but regarding shape of the head, was there in any kind of plagioccephaly or any suspicion of any subtle dysmorphism as well as craniosynostosis? So these are few points which I want to know from you from the history in the examination. Sorry.
Actually, her head was normal. There was no no pointers towards craniosynostosis or plagiocephaly, anything. Head was perfectly normal. And then regarding the gaze,
Voice is not very clear. Please, can you close to the microphone?
Hello, ma'am.
Yeah.
Ma'am, regarding the head position was normal. No plagiocephaly or synostosis. Then concern the range of eye movements, only abduction palsy was there. Other than her movement towards right, like upward gaze, downward gaze, everything was normal. And then the child was not having any nystagmus, ma'am.
And you did not comment anything about field of vision.
Field of vision was,
you should mention.
Yes, ma'am. Confrontation test was normal. Her field of vision was also normal, ma'am.
Okay.
Yes, ma'am.
You told field of vision is normal.
I could not see that in, I think, in your examination slide, but if you say it was normal, and I believe.
Okay. So, so basic thing, after your history, you have put a summary slide.
Yes, sir.
And then after your examination, we have a summary slide. So what are all the additions you made after your examination? Can you tell me point by point? What is the yield from your examination? Additional yield from your examination. At the end of the history, you made a summary. So you understood something about the patient. And then you made the examination. With some idea, you proceeded with the clinical examination. You did clinical examination step by step, system by system. And you made a complete summary. Okay. So what is the difference between your summary of at the end of history as well at the end of examination? Means, in other words, what is your yield out of your examination?
So first thing I want to rule out after examining is to rule the possibility of meningitis or meningoencephalitis, sir. That is the first thing. And following that, inflammatory conditions and then cerebral venous thrombosis or the other conditions I would be looking for, sir.
Okay, sorry, I reframe my question. I think you didn't get my question correctly.
See, what sir wanted, sorry, no, what he wanted was...
Yes, Mullah. You can reframe it better.
What he wanted was what additional information are obtained from the clinical examination, so that you see, we are not talking about the differential diagnosis. So we have headache and diplopia, double vision, squint, all that in history. Now extra points what we have gained from the examination. That was what sir was interested.
So after the history, after the examination, I would be sure that child is not having other forms of deficits like weakness or sensory involvement or bowel and bladder habits. These things were not affected except the sixth cranial nerve palsy. Other than sixth cranial nerve palsy, other neurological examination is found to be normal, sir.
Okay, Dr.
Okay.
Salima, can you add to this? Whatever
you can put the previous slide, and from
Previous.
that you can add. Everybody can understand it better. So the previous slide is the summary slide, I think. Yeah. So to me, it looks as if you understood that the child has bradycardia, which is an important finding. Papilledema, you have confirmed, and bilateral lateral rectus palsy is there, and signs of meningeal irritation is there. What I was asking is indirectly, we were waiting that some neurocutaneous examination findings you are going to say. At least the skin examination becomes one system of interest in this case. Okay, because there already involvement is there. So here also the summary I am able to see only history of vitiligo, nothing more. So is there any further yield? Can you say whether it is a segmental vitiligo, non-segmental vitiligo, mixed pattern? What is the distribution? Anything more you have to say?
Nothing, sir.
Nothing. Okay, so we can proceed. Yes. Any question from anybody else? Mullai or Renu?
There were a couple of chat box questions. Was the child able to sit or able to stand or anything?
So the child was able to sit, but she was not able to stand, sir, because of pain and blurring of vision. She was not able to stand, sir.
Okay, and Dr. Salima, what will be the relevance to bradycardia here? Do you want to?
There is a feature of raised ICT is there. There will be features like hypertension, bradycardia will be there. So vitals are very important when an acute onset of headache is presented, sir.
What is your definition of bradycardia?
Heart rate less than, according to the heart rate, if you are a 10-year-old girl, so heart rate less than 60 will be relevant, sir.
So here heart rate was less than 60?
Yes, sir. Whenever she is calm, because always she'll be agitated because of the headache, sir. So whenever she will be calm, her heart rate always go with around 40, it will go, sir.
Around 40. Okay. So that was significant bradycardia. Okay. Okay. So coming back to the question what I have asked, because we have a little bit of time. Do you think describing about this cutaneous lesion is important or unimportant?
Yes, sir. Certain neurocutaneous syndromes can have intracranial lesions, sir. So if any other neurocutaneous markers are present, we can that maybe DDs will be other neurofibromatosis, tuberous sclerosis. They can have intracranial lesions, sir.
Okay.
So they can present as headache.
So I understood that neurocutaneous lesions are important. You ruled out neurocutaneous lesions by head-to-foot examination.
Yes.
Whether this vitelligenous lesion distribution is important or not? Always consider skin as a system. Okay. Whenever there is an autoimmune disease, we discuss skin is a system. Okay. Skin involvement, if it is a non-segmental vitiligo, then it becomes a first autoimmune systemic manifestation. Okay. This is very simple, basic. It is a autoimmune systemic manifestation if it is a non-segmental vitiligo. Okay. So the way you described front and back in the trunk as well in the groin area, it looks as if it is a non-segmental vitiligo. Then it becomes a first systemic autoimmune manifestation. Okay. Vitiligo is no more just a cosmetic lesion. It is a autoimmune manifestation. So that's why it becomes important. Okay. Can we move further?
I have one question for any of the student who wants to take it. So what is your impression regarding these examination findings? as I asked you timeline in this case, so what do you think? She has hyperacute, acute, or subacute, or chronic kind of? She has features of raised ICP. Definitely, she has. So, what do you think her time course in this section? And based on time course, what differential should be thought of?
Based on the time course, the differentials thought would be
So first take the
infection.
question whether it is features here are hyperacute or acute, or it is subacute kind of raised
It's a
ICP in this.
acute kind of raised ICP, ma'am.
Can you further elaborate? Why do you think it is acute, or why don't you think it is a subacute?
Because the symptoms are present for the past 6 days only, ma'am.
Okay, but you must have seen children with acute presentation, children who comes with encephalitis, who comes with the acute meningitis. How commonly you see papilledema in those cases?
Very rare, ma'am.
So the question is that how much time it will take to have papilledema if you have raised ICP. Typically, we see papilledema in children who has a kind of a chronic or a subacute kind of headache. So what do you think from her examination finding? Do you think it is an acute disease or it is a subacute which is acutely presented to you?
It might be a chronic disease which is acutely presenting to us, ma'am.
Yeah, so definitely this doesn't look a kind of, these examination finding doesn't, we normally do not see children who have very acute in terms of when we have vascular events like SAH. SAH can come with the catastrophic headache within 24 hours. You get a meningeal signs, afebrile totally, and it is a thunderclap headache. So that kind of presentation is not there. Acute, we have also seen children who presents with acute encephalitis, acute meningitis. They may not have encephalopathy, but still they do not develop papilledema so early. So presence of LR palsy bilateral and papilledema in this girl possibly suggests this was a subacute kind of presentation. Okay. And she has aggravation of symptoms within last 7 days, possibly, because my understanding is that this is not really very acute. She presented acutely though, but she must be having those symptoms slightly longer duration. Okay, then your DDs will change accordingly.
Okay. So our DDs will be here first inflammatory conditions and immune pathologies and then infections, ma'am. Mainly we should, since it's a subacute or chronic thing, meningitis or meningoencephalitis with an atypical organism should be considered here first, and then following that cerebral venous thrombosis or any vasculitis kind of neurovasculitis kind of thing, as sarcoidosis, those kind of differentials will come in this child, or in any intracranial space opening lesions we should think of, ma'am.
Okay, when you have pathologies like intracranial space occupying lesion, why should they present suddenly acutely? What pathology would make them to present acutely? Dr. Salima?
Most of them will present as like, there are two types. Some tumors can present as slow growing tumors, present very late, and rapidly growing tumors usually present with the acute onset of symptoms. They usually present with the altered sensorium. Seizures will be present, and there will be hemiparesis, signs like that will be present. So headache, vomiting. Apart from that, there will be seizures, hemiparesis, focal neurological deficits will be there.
No, I think you're just saying about general presentation of ixols. I mean, what I was asking is, since here we are considering something as a subacute pathology, what would have resulted in an acute presentation in such a kid, if in case we are considering intracranial space occupying lesion?
Sudden hemorrhage into the lesion can
okay.
Midline shift and raised intracranial pressure.
One could be hemorrhage. What else?
Herniations.
Okay, so herniation, how do they present?
Child will have much more symptoms like altered sensorium. The child will be drowsy or often.
Okay, see, herniation is a very hyperacute and emergency condition, right? They will not be sitting from Kerala coming here and some hospital admitted, and from there they are coming to your hospital. 3-4 days have happened, so they are not typical of herniation syndromes, right? They just expand over few seconds to minutes, and it's just about few hours that they become totally irreversible neurological injury. So you cannot tell about herniation. Bleeding into the tumor is one possibility. What other common possibility can happen with ICSOLs? Due to obstruction to CSF outflow, what can happen? They can develop hydrocephalus, right? So something like a subacute slow-growing tumors, if they either bleed into the tumor cavity due to a rapid progression necrosis of rapidly proliferating cells, or they cause obstruction to the CSF outflow tracts. So they can develop hydrocephalus, and then they can develop acute symptoms like presentation with headache and sudden onset. I mean, again, raised ICP signs like bradycardia and those stuff. So in ICSOL, complicated by either bleeding or hydrocephalus can be thought about in such a presentation.
So I'll reframe this question. What are the tumors who presents with this kind of presentation where you can have raised ICP without presence of focal findings? Brainstem involvement can be there. So which are these lesions? Where do you think they are located? So they cause just a plain raised ICP. They don't cause lateralizing symptoms like you said, hemiparesis, seizures, and focal neurological deficits. So which are these lesions which comes with early signs of raised ICP? Okay, so I'll take this. So midline tumors as well as posterior fossa tumors. So they may be initially asymptomatic, but once they cause obstruction, they present acutely. So some of the examples are like medulloblastoma, which comes in the posterior fossa, sometimes tumors in the third ventricular area, penile lesions, craniopharyngiomas. These are the midline tumors who comes with the early hydrocephalus and raised ICP. Rest of the lesions happens in the cerebral hemispheres like astrocytoma and all oligodendroglioma. So they do not cause initial raised ICP. They cause initially more lateralizing symptoms of signs like seizures and hemiparesis and focal deficit. So these are the lesions which are the midline, usually presents with more acute and catastrophic presentation.
Yeah, can you move ahead? Yes.
So the differential diagnosis considered in this case was mainly intracranial space-occupying lesion, CNS infections, cerebral sinus venous thrombosis, and inflammatory conditions like ADEM and neuromyelitis optica. And there are some points which favored intracranial space-occupying lesion becoming the first DD because there were symptoms of headache, vomiting, diplopia, blurring of vision, as well as backache, and there was no fever which was present. There were features of raised ICP as well as neck stiffness, and the points which were not which were against the ICSL was acute onset of symptoms, and other neurological signs like weakness and all were absent. CNS infection can be considered due to the rapidity of symptoms and her recent history of travel. And she had meningeal signs and raised ICP features, but strongly against was the absence of fever, and there was no change in her sensorium, and there was no seizures. CSVT can also be considered due to the acute onset headache, and there were also features of papilledema and raised ICP. But there was no hypovolemia causing conditions like loose stools, and she was not dehydrated, and she did not have fever too. In case of ADEM and NMO, the points which was favored was the acute onset, papilledema, and features of raised ICP, and she's also having vitiligo. So other autoimmune conditions should also be thought in this case. But there was no encephalopathy, no seizures, and no recent infections or immunization in the past, which was recently done, and there is no visual loss. So coming to the management of this child, the child was admitted in our ICU and investigations were done. Initial counts and electrolytes were normal. The inflammatory markers were also normal. MRI brain showed suspicious flare changes in the basal systems with patchy meningeal enhancement in the posterior fossa. There was also mild contrast enhancement along the bilateral 3, 5, 6, 7, and 8 nerve complexes. So these are the images. There was also bilateral prominent perioptic CSF space with flattening of optic nerve head, which was suggestive of raised ICP. MRV was normal, which ruled out CSVT. Her optic nerve sheath diameter was 5.7 millimeter, which is high. A lumbar puncture was also done, and it revealed markedly elevated opening pressure of 79 centimeters of CSF. And her CSF biochemical analysis was normal. The gram stain, AFP, intake preparation, and fungal staining was also negative. CSF culture and CSF AD was also negative. So from the CSF analysis, we could not make any signs of infection. So the MRI had pachymeningeal enhancement. So the causes which are common are infections, encephalitis, cerebral venous thrombosis, neurosarcoidosis, tuberculosis, intracranial tumors, and granulomatosis with polyangiitis. So we also sent a detailed infective panel, including strep-typhus, malaria, leptospira, HIV, TB, gene expert, toxoplasma IgM, Brucella IgM, cryptococcal PCR, viral PCR, which all turned out to be negative. Her ANA was weakly positive, but C3 and C4 were normal. So the possibilities of infection was narrowed down. A PET CT brain and whole body was also done, and it showed no metabolically active FDG uptake. But there was scalloping of calvarial bones which was seen, and this is classically seen in chronically raised ICP. And meanwhile, her CSF anti-MOG autoimmune panel ACE levels all came, which were all normal. The CSF flow cytometry was negative for malignant cells. So we also considered a possibility of ophthalmoplegic migraine versus idiopathic intracranial hypertension.
I think, Dr. Lakshmi, we can discuss some of the investigations you have done in this patient. So, Dr. Balaji, do you want to take here anything?
Yeah, we'll just go back to the imaging.
Right.
You said.
So now the first question is whether you will go for a CSF in this child, and when you decide you should go for a CSF in this child, what are the safety concerns in your mind? She has got a bilateral papilledema.
In case of raised ICP, will differ.
Bradycardia. So how will you decide that CSF would be safe in this child and I should proceed with the CSF?
Ma'am, we have after MRI, we have ruled out any intracranial space occupying lesion and any obvious infections.
No, you did an MRI infection. You cannot rule out with an MRI. You can just rule out SOL in this with an MRI. But how do you rule out an infection? So my question is that how do you decide that LP would be safe and I can proceed with LP in this girl? That is a one question I think everybody should have in their mind when you face such kind of a patient.
Yeah, from your clinical examination as well as from the MRI, you can tell the answer.
How did you decide in this index child? Because you have done it. So some discussion would have gone and then only they would have decided, no? So you told the heart rate goes up to 40. So how this was decided?
Sir, initially we did not do a CSF analysis and it was done after a day. We initially treated her with the anti-edema measures and we saw and her sensorium remained normal and she was clinically stable. LP was done after she improved clinically, sir, and we ruled out this main causes like intracranial space occupying lesions, CSVT.
Other PGs have anything to add?
Salima.
So, all the other ruled out all the other possibilities like space occupying lesions. Like ruled out, the counts were not suggestive. So imaging also and possibility of.
No, I think the question is not why you did CSF.
No.
The question was like, how did you consider the safety of getting a lumbar puncture done in this child? See, every one of us, because tumor was one of the differentials and then infection and inflammatory condition was there, CSF was in order. The question is, based upon your clinical findings and imaging or other corroborative findings, how do you decide that it is safe to proceed with lumbar puncture?
Imaging and all ruled out, so it is papilledema, everything is present. So it is a chronically presenting symptoms because of the presence of papilledema and all.
Okay, see, one subtle point, as Renu ma'am had already told, papilledema doesn't occur in few days. So that means some ICP is already present for quite some time. In imaging, again, you have the elevated perioptic CSF spaces. And so those findings again don't occur suddenly over a few days' time. And what about her sensorium? And
there is no altered sensorium was present.
Okay, any other imaging you will take into consideration? Especially in this, you have put some. What are these black things? Okay, we also take into consideration basal cisterns. How are they? Whether they are opened up or whether. See, basically for herniation, you should have some gradient, pressure gradient across two different compartments so that it flows, right? So you have a big hydrocapillus sitting, obstructive hydrocapillus, then obviously you will not be safer to do an LP. And again, when your basal cisterns are very compressed or chinked, we call it as chinked, then again, that means brain is tight and any attempt at putting a needle would cause transtentorial herniation. So one is your clinical, your GCS, and you said that you stabilize the patient for a day or two and then observed her, how she progresses, with, especially with respect to sensorium. Second thing is with imaging finding, you can get some of these ideas. Renu ma'am, do you just want to add any further?
Yeah, so I want to say. Yes, sir, please go ahead. I will take it later.
No, basically, they have to tell about the cautions taken while doing the LP in such cases. So that, okay, this is a subacute raised ICP, but the severity at this point of time, at the juncture of a clinical examination, it's very clear that the child is having a severe raised ICP. So you have all kind of symptoms, which we rarely see, bradycardia 40 and all, we rarely see. So everything is there. So even if you take a decision of raised ICP, okay, we have no cause, so we have to proceed with LP. What are all the cautions? What is the method in which you will do? So that is what we want you people to explain. So any of the PGs want to take up, then I think if Renu comment, then it will be appropriate. Yes. If they want to say about the cautions while doing LP in such patients.
We have to stabilize the child, and there should be adequate sedation, and the child should be pain-free, and adequate. We should be properly equipped to resuscitate the child in case of any emergencies.
Would you like to give any medicines? What did we do exactly here? Perilumbar puncture.
Lignocaine, local lignocaine should be given. And adequate analgesia should be present. Sedation.
Any role for osmotherapy or something?
Yes. Osmotherapy, yes, sir. We have to give a mannitol as well as 3% NaCl, 3% saline to decrease the raised ICP.
Okay, any other thing? Needle, any size is there? See, we have to go arranging prior to LP and during LP, like what needle would you want to use any specific needle, or what would you want to use? Okay, fine. See, we don't want to have a gush of CSF coming out, right? So ideally, I mean, as you said, we have to take all precautions that we are able to resuscitate the patient or anything. And we give some time osmotherapy or something to act, and even peri-procedure, we can give a dose of mannitol or 3% saline so that any acute rises in ICP are catered to. And you use the thinnest possible needle, and you use a lumbar puncture needle. You don't put a needle with a stillet so that the CSF doesn't gush out. And many times we have to, here we use a 3-way stopcock so that you are having a control over drainage of CSF that comes. You don't just put in a needle that suddenly there will be a gush. So if you are able to do that with a stopcock, then you can have some control over the amount of CSF that can be drained or something. So these are some of the precautions. I'll just ask one more question before I think I'll hand over to Dr. Renu ma'am. Is imaging mandatory before? This is a different scenario. Is imaging mandatory before doing a lumbar puncture, or does imaging rule out ICP in a child in whom you plan lumbar puncture? Dr. Salima, I think can answer.
To rule out the edema infections, all the cases prior to it.
I think your voice is not clear. You can come close to the microphone.
Whenever you are suspecting a lesion, to rule out the raised ICT, you can go for imaging, sir, before planning for LP. But clean.
No, somebody has a normal CT. Would you be happy that there is no raised ICP and go ahead with lumbar puncture? That is my question.
Sir, any hypertension, bradycardia is there, you won't go for the LP, sir. Clinically, you have to look for.
Okay, fine.
Not completely depend on the imaging.
Yeah, so it is important that you take into the picture the clinical findings as well. Somebody has posturing, has anisocoria or something, even though the images may look apparently normal, we don't take that imaging is normal and it's safe to do with LP. So it is not clinical alone, it's not imaging alone. We have to take a combination of both and then weigh the benefit versus risks. So I think Renu ma'am, yeah, please.
Okay, so I want to ask, what are the 4 or 5 most common contraindication for lumbar puncture in ER setting? I think if you know these, then we can proceed that what are the safety measures you should take. Can anyone of you tell what are the 4 or 5 absolute contraindication?
The clinical and of course radiological.
Yeah,
imaging.
radiology as well as labs.
Clinically, the presence of hypertension, bradycardia, and then other contraindications are any space occupying lesion with a mass effect, definite features of raised ICP.
What are the clinical signs of herniation?
Any active bleeding, you are suspecting any bleeding disorder, thrombocytopenia.
Okay, so I'll take it from here. So absolute contraindications are presence of raised ICP. That could be in terms of your brady, papilledema, any kind of pupillary abnormality, posturing, extensor posturing, or you have a pupil mid-dilated or any kind of anisocoria and all. So these are the absolute contraindications. Second would be presence of any focality in a child who comes with acute raised ICP, presence of infarct, or if you have a hemiparesis, monoparesis, or lower limb paralysis. These are usually suggest there would be a mass effect or there would be a midline shift in the imaging. Third third absolute contraindication is presence of any bleeding diathesis, and fourth is that could be thrombocytopenia or like a coagulopathy, and fourth would be a local site infection. So these are the some of the contraindication, but what are the most important 2 points are that signs of raised ICP as well as presence of focality. So in this situation, you would want image before you proceed with the CSF. Presence of a normal sensorium would be in favor of that. You are not dealing with the possibly kind of herniation syndrome or that, but you have to take a decision based on your clinical examination as well as radiology. So in this case, you had Brady as well as she has got a papilledema. So definitely an imaging was warranted before you proceed with the CSF in this case. So if your image does not show any kind of a midline shift, like it could be a CT. In our setting, it is a CT, which is done in ER settings. So if a CT you have, which does not show you a midline shift on a herniation, uncal or transtentorial herniation, your CSF spaces in the fourth ventricle and the basal cisterns are open, and your, as in this case, GCS is okay, then you can proceed with the CSF in such situation where you have these contraindication. So for some of these indications are when you have a adolescent girl with IIH. So typical example is IIH, where they have severe headache and you have this kind of imaging and you need to go for an LP. So you get an image, no midline shift, you proceed with the LP. Second typical example is a cryptococcal meningitis, where you have a chronically raised ICP kind of features and you have papilledema. In that case also you have to go ahead, if your basal cisterns are open, posterior fossa is open, and there's no midline shift, you have to go LP to do repeated LP basically to relieve pressure in those settings. So these are the two typical examples where you have to proceed with the EG, with the CSF in presence of a raised ICP setting. Okay, and the precaution is that again, as Dr. Balaji and Dr. Sashidhar has already told, that you should be ready with the resuscitation equipments with you. It should be a pain-free procedure, and you have to use a very actually we use a very thin needle in such situations rather than using a 24 gauge needle which commonly used for CSF. So use a thinner bore needle, and guarded LP is usually recommended, but mostly it is a thin needle, and you use that manometry along with you with the 3-way stopcock so that you can control the release of CSF. It should not be like sudden gush of flow of CSF and then you can have it may not be transtentorial herniation in this setting, but it may be a descending kind of midline herniation can happen when you have a rapid shift of CSF pressures within the compartment. So these are the precaution and some contraindication, and you should know when we have to do CSF in presence of a raised ICP situation. Anything you want to add, Dr. Shashidharan or Dr. Balaji, based on your experience? Would be happy to
basically what you have done also, it's a guarded LP because you have told the opening pressure. So 100% you have used the manometer, and Mulay has clearly told it's with a 3-way. So without 3-way, you won't be able to attach your manometer to the hub of the needle. So the needle should be, usually we use a 26 LP needle. LP needle, which is like used by the anesthetist. That's what is having a stillet. So 26 LP needle, 26 gauge LP needle, which is used for anesthesia, lumbar puncture, or spinal needle. And you have to use a 3-way, attach it to the manometer, and open it to an extent that first you have to measure the pressure, which is quite difficult, and it is sometimes it becomes subjective, which I understand. And after that, this is the method of guarded LP. When we say this is the guarded LP, and obviously a child like an index child, the child is having a severe raised ICP features, 100% we would have given a dose of osmotherapy. It's not both mannitol as well 3% saline. We will choose either. If you give mannitol, you give mannitol, or you give 3% saline loading dose of 5 ml per kg. So either of the one will be given. And very important is pre-procedure, peri-procedure. During the procedure, you have to be cautious. Post-procedure monitoring is maybe the most important. Okay, so all these things need to be taken care of. So Mulay, can we go to the next question?
Sir, can I ask a question, sir?
Yes, sir.
Yes, sir, please.
Now tertiary care centers where you have facilities for CT and MRI, it's okay. You can do all this investigation. In smaller centers, Usually, conventionally X-ray skull lateral used to be taken when you suspect raised ICT. When anyone of the learners say that, what are the signs of raised ICT in a lateral skull X-ray?
At least I do not have any idea, sir. Any comments from Renu or Mullai?
Yeah, so we do this lateral X-ray in children with the IIH basically, and IIH or sometime when we suspect some SOLs, or SOL we don't use because it's obviously visible in the MRI, but in children with IIH we do sometimes do X-rays. It may show you some kind of scalloping or of the inner in the CT. I'll say it shows scalloping of the inner table. In X-ray it will show you silver beaten or copper beaten appearance, where you have areas of rarefaction with areas of hyperdensity in the X-ray. So it's more or just an academic exercise, but we do not take this X-rays for taking a clinical decisions.
But it is a good picture, good investigation, because you can see the erosion of the clinoid process, and a J-shaped cella can be visible, and what is said as silver beaten appearance. They don't beat silver anymore. We call it digital impressions, and also J-shaped cella, erosion of the anterior clinoid process, and digital thumb impressions. These are the findings. Very simple. Those days when CT and MRI was not available, and even now in smaller hospital, when you are not able to see that and you have no chance of referral, just at least to decompress the raised ICT, we can do this in a simple investigation. Thank you, sir.
So what I would add is, sir, if it is a subacute or a chronic ICP, maybe this may be quite an available alternate option to proceed with. But when you are managing, the index case is a subacute to chronic, it is quite understandable it is subacute. If it is a hyperacute or acute presentation, you may not be able to bet on X-ray to rule out ICP. Rather, you put your bet on clinical examination. If it is such a significant raised ICP clinically, then believe that the ICP is so significant and you can delay the LP. That may be a better alternative when you do not have imaging on hand, like imaging like CT and MRI on hand. Mullai, any further questions here?
No, sir. Just one point I just wanted to add, that lumbar puncture, what Dr. Renu ma'am had said. One more thing is a kid who is immunocompromised. So in those conditions also, in emergency prior to doing a LP, we get an imaging, just because we can have some surprises. We can have SOLs, we can have fungal balls. So any kid who is known immunocompromised, especially your leukemias coming with sudden seizures or altered sensorium, where a wide gamut of differentials can be considered. Even in them, you always get imaging to look for SOLs in the form of infectious SOLs like abscesses. You can have tuberculomas or cryptococcomas or any other aspergilloma. So those things. So even in them, imaging becomes mandatory. Apart from those many other conditions told by Dr. Renu ma'am prior to doing an LP. So there were a few questions in the chat box. I think, PRC sir has said, like X-ray changes or these skull changes may suggest chronicity. So when we are clueless whether we are dealing with subacute or chronic, these subtle findings, like in this child, the PET CT picked up, but a simple X-ray might also pick up the chronicity of symptomatology, especially when history is not forthcoming. There was history, like whether there was any family history or any bipolar symptoms in the family members. Going back to the history, did we get any such symptoms or history in the?
Sir, actually, there was a detailed evaluation later on from the psychiatrist. The mother had some anger issues and everything, and which was present, sir, and which made the child a little bit uncomfortable. And
okay, so there are some baseline, some family concern which could aggravate the existing condition. That's what you are probably trying to say.
Yeah, I think this question is relevant when you have a differential diagnosis of a primary headache into your picture. So here we are dealing clear-cut a case of a secondary headache with raised ICP. So a psychosocial history may not be that much relevant, but I agree if you have a primary headache and recurrent presentations, definitely psychosocial risk factors becomes very important.
Please be very clear when you ask this kind of family psychosocial history, means neuropsychiatric symptoms in the family members or in the index patient. Whenever you take the family history, do not overrate the subtle things. Obviously, you do not want to miss out the bigger things which is hidden, but do not overrate the subtle things which are coming up. Okay, some this angry issues. How much weightage we can give to that? Not very clear. So this is a family history which has a uncertain significance. So you can't say that it has a very certain significance. So this much you have to understand when you are taking this kind of history. And any other questions related to the investigations? I have few questions related to the investigations. You told about viral PCR. So what type of viral PCR, what are all the things you have excluded for everybody to understand?
Sir, in viral PCR, mainly we screen for the common viral infections like herpes.
No, what did you do in this index child? Now we have come to the management. We are going to discuss only about the index child, whom we are presenting to us. You are presenting.
Okay, so the viral panel, what we sent here is consisting of 6 viruses, and mainly enterovirus, varicella, HSV 1 and 2, and herpes.
Okay, varicella, HSV 1 and 2, and HSV 1 and 2. Okay, so these investigations, viral PCR came negative. Okay, so let us be precise. Whenever you put these investigation, be precise about that. And another thing what you need to be precise is CSF autoimmune panel. So what is CSF autoimmune panel? Can you tell us what is the investigation, what you have sent?
Sir, CSF autoimmune panel mainly for autoimmune antibodies.
What antibodies?
So NMDA antibodies,
Okay.
then VGKC,
Okay.
then anti-MOG.
Okay. So you have done the whole panel and the whole panel came negative. That's what you are trying to say. And you have sent a paired sera sample. So you have done a MOG sera as well, blood sample as well, CSF sample. Is it right?
Yes, sir.
Yeah, because these things are, when you are moving towards narrowing down your diagnosis, all these things are going to be very important. So you can't say autoimmune panel negative. You can't say viral RT-PCR negative, nothing like that. Okay. And CSF flow cytometry, that I am not able to understand. So what flow cytometry was done?
I want to come in here actually regarding some of these investigations.
Yes.
Okay, so I think we have very two important investigation, MRI and a CSF you have done. CSF, you said there was no significant pleocytosis, protein and sugar was normal. And you had MRI, which showed suggestive of chronic changes of pressure with the optic nerve sheath dilatation, flattening of the globe. Some other features are there which you have not told here, but I want to know what is the indication to do an autoimmune panel or NMO or MOG in this panel. So, so you should have some explanation. Why did you do that? Your MRI did not show any kind of white matter changes. Your MRI did not show any kind of optic nerve or chiasmal changes. And regarding this autoimmune panel, so her phenotype was not like an autoimmune panel. Autoimmune encephalitis, there was no movement disorder, there was no seizures, there was no significant behavioral issues or hallucinations, or so you need to explain why did you send these investigations. I agree with the CSF flow cytometry because you have some pachymeningitis, you want to rule out certain infections. you want to rule out a malignant pathology. So I agree with these possibilities, but what is the need for doing an autoimmune panel and CSF and MOG antibodies here?
Mainly due to the rapidity of symptoms, and as you said, ma'am, the child did not have any encephalitis, but before excluding other cause for there was also subtle pachymeningeal enhancement in MRI.
So for that, I told you, if you have like a pachymeningeal enhancement, which was reported to you by radiologist, usually an infective pathology or some kind of inflammatory pathology could lead to pachymeningitis, sometime like tuberculosis or your cryptococcus or some of these scrub typhus, sarcoidosis. They can have this kind of presentation, but typically a MOG, a NEMO does not have this kind of presentation. And even autoimmune panel would not have that kind of presentation. So I would not definitely do these panels in this case. I think we have to rationalize our investigations also. You proceed with your investigations. You did not have significant pleocytosis. You did not have parenchymal changes here. So it would be very less likely in this situation. So evaluate for conditions which can cause pachymeningitis or cranial nerve enhancement, as in this case. Those are infections, some inflammatory conditions like you can have SLE or you can have neurocytoidosis or sometime a malignant pathology. These are the conditions which can cause. But I would not do these investigations if we have this kind of a clear-cut raised ICP where you have signs of IIH in MRI. CSVT is definitely you need to rule out with MR venography in that situation. But CSVT usually presents with some hemorrhage also in addition to thrombosis. So you have a acute presentation with hemorrhage as well as CSVT. So this is my take on these investigations.
Good. Actually, it's good to involve more people. And the thing is, CSF flow, when you are saying an investigation, please do understand and tell that, because you have told 5 cells in CSF cytology, all lymphocytes. Is it right?
Yes, sir.
This is your yield. Okay. So if you are ruling out malignant cells by malignant cytology, that is not flow cytometry. Okay. So that is not by flow cytometry. They are going to see the morphology under the microscope and say that it is not a malignant cell. So that is ruling out of malignant cell under the microscope. Okay. So if you have a huge cell count, 70% polymorph 100 cells, then you may end up in doing flow in the microscopy if they are suspicious of malignant cell. This is my understanding. Renu can correct me like if I'm wrong. So in this 5 cells, I think that what you quoted as flow is microscopic examination to rule out malignant cells. Is it right?
Yeah, it's a cytological examination under microscope for morphology, basically.
Morphology,
so,
basically.
But presence of 5 lymphocytes is absolutely okay.
Yeah. So absolutely okay to do a microscopic examination to rule out malignant cells. So if it is done immediately, okay. So you know that malignant cells have a highly unstable. They are immature cells. They will degranulate quite fast. So you have to shift it so fast to an extent that you have to done the malignant cytology immediately. And that cytology is not flow cytometry. That is just a simple microscopic examination. This becomes very important, because people should not go with an idea that malignant cytology cannot be done if my lab is not having flow cytometry. That becomes completely wrong. It may be a disaster. So that should not be the thing. This is just simple a microscopic examination any pathologist can do. Okay, so that is one. A second thing, another few investigations, whether you have done free T3, T4, TSH, anti-TPO antibodies have you done? My question was almost converging on that end. So that's why I was asking about your autoimmune panel. So if you are not doing an anti-TPO antibody, T3, T4, TSH in this child, and doing a complete extensive autoimmune panel, that really clinical, it doesn't make a clinical sense. I may not say like Dr. Renu that you don't do autoimmune panel. Maybe our thresholds are low, or we are not neurologists, we are intensivist. Perspectives may be different, but I would rate anti-TPO maybe first on the court. So T3, T4, TSH and anti-TPO antibodies is very important if a child is having vitiligo presenting with acute headache. Okay, you cannot rule out Hashimoto's thyroiditis. 100% you have to do that. It is rule of thumb. Do you have these reports?
Actually, no, sir. I only typed it.
So this
you didn't type
important.
it, but anti-TP was negative. I think she didn't type.
Okay, so this is very
I
important.
want to ask one question. Vitiligo itself can be a sign of autoimmune, indirect evidence of autoimmune problem.
So that's what our takes. So we think that if it is a non-segmental vitiligo, that's a first systemic autoimmune manifestation. So other systemic workup has to be done. Other autoimmune workup need to be done. But what Dr. Renu says carries a great weightage, because we have to narrow down the investigations accordingly. Whatever symptoms in the index case, we cannot even distantly correlate with the anti-NMDA disease or anti-MOG disease. So that we are not trying to do, but like potassium channel diseases or anti-LI1, GAD65, all this can have a very complex presentation. Our experience with those are very less, so we end up in doing that. But anti-TPO, T3, T4, TSH, that makes a huge sense when a child is having vitiligo, because non-segmental vitiligo and Hashimoto's thyroiditis is an extremely well-known combination. And Hashimoto's can present with the isolated intracranial hypertension. So that is a very well-known presentation. Okay, so those things are very important. Okay, so any more questions, Mullai?
There was a question like this child now having this imaging finding, some papilledema and all. We know that she's been having this ICP for quite some time. So what compensatory mechanisms do happen which makes the child asymptomatic till now, and suddenly she has presented with headache? No. So physiologically, what are the compensatory mechanisms that happen when you have raised ACP? How does our body adjust to slowly growing raised ACP? We can understand when sudden bleed is happening, we don't have any mechanisms to compensate. But in a slowly growing raised ACP, what compensation happens?
There can be decrease in the cerebral blood flow and decrease in production of CSF. In case of raised ICP.
No, decrease in cerebral blood flow, what will it cause?
Then hyperventilation, because carbon dioxide.
Other PGs can try to contribute.
Dr. Kritika and Salima.
Adjustment to cerebral blood flow, because the cerebral intracranial pressure will be constant. So to compensate the raised CSF, there will be other blood flow will be decreased.
So basically, what happens in the intracranial? What are the compartments that are present?
Brain parenchyma, CSF, and blood work.
We have CSF, we have blood vessels, and we have brain, right? Okay, so if somebody has a slowly rising ICP, we have something called a spatial compensation. So the CSF from the intracranial compartment can get shifted into the spinal canal. So this especially happens when you have slowly rising ICP, not in acute cases. So these may be some compensation that happens. And we also have something called as intracranial volume and intracranial pressure curve. That's called as a compliance curve. So it's like a sigmoid S-shaped curve. So some rises in the volume can be accommodated without any rise in ICP. So till one point. And when the volume exceeds that particular level beyond which the compensatory mechanisms, the spatial compensation, all that exhausts, that is when the pressure rises, and then that is when they become symptomatic. So that is why they can tolerate quite some time of raised intracranial volume. Basically, the volume is first high, then it slowly compensates. But when it goes beyond some point, then the acute pressure rises and then they become symptomatic. And this holds good mainly for chronically slowly evolving problems and not an acute pathology like trauma, bleeding, or an infection. You have sudden inflammation of meninges, and those things they have an acute presentation. Yeah, Shashi sir or Renu ma'am, anything else?
Dr. Renu, anything to at this juncture, or should we take her to proceed?
Okay, I'll take that question of again autoimmune panel. So if we think of autoimmune disorder, we should understand there are systemic autoimmune disorder and we have a CNS inflammatory disorder. So systemic autoimmune disorders, I definitely agree that she should be ruled out in the index case. ANA, C3, C4, Hashimoto thyroiditis. She should look for hypo as well as hyperthyroidism. I agree with that. But the problem with this autoimmune panel is typically consists of just 5 antibodies, which are AMPA, NMDA, GABA A, GABA B, and one more, and VGKC. So this panel is usually is associated with more epileptic presentation with lots of neuropsychiatric and sometimes status kind of presentation. What the other antibodies are there, which are associated with paraneoplastic syndromes like anti-Hu, RILA, they have more subacute presentation and usually they present with some kind of opsoclonus, myoclonus syndromes and sometime neuromyotonia, and their presentations are usually different. So that's what I want to say, that when we say autoimmune panel, we should know what we are asking for the index case. Even for the LG1, a child without seizure will not present with LG1. So they have a little subacute to chronic, but seizures will be dominant symptoms. So in that setting, I would say that in the absence of a demyelinating lesions or absence of white matter lesions in the brain, MOG or an NMO would be very less likely to be positive. And similarly, if you don't have seizures and encephalopathy or status-like presentation, possibility of having an autoimmune panel positive will be very, very less likely. So I think that's, I want to say that at least we should rationalize an investigation based on the prelim investigations which you have in your hands, basically.
Yeah, completely well taken. Yes.
Yes, ma'am.
Dr. Lakshmi, can you proceed with your presentation? Do you have something more? I think. No?
Yes, a few more slides, sir.
Yeah.
So the possibility of migraine was also considered in this case because since all other investigations were negative, so the points which were favoring was headache, vomiting, and photophobia. But the absence of aura and such a high CSF opening pressure with the and there was no persistence of symptom for a longer duration. And this was only her first episode, and there is no family history of migraine too. So which made the possibility of migraine less likely. And the other possibility was idiopathic intracranial hypertension. And the points as we see which were favoring this diagnosis was the clinical signs of headache, diplopia, vomiting, absence of fever, and the signs of raised ICP. And but the rapidity of onset of symptoms was against this diagnosis, and after all, it's a diagnosis of exclusion only. So a trial of oral gabapentin and triptan was given to this child, but the symptoms of headache persisted and the features of raised ICP and diplopia was persistent. Hence, since it was not responding to any other medications, we were quite sure that we were dealing with a case of idiopathic intracranial hypertension. We also did a repeat MRI, and there was bilateral prominent and protruding optic nerve head, and the pachymeningeal enhancement which was there in the first was absent. And all these were features suggestive of chronically raised ICP, repeat MRI showed an opening pressure which was much lesser and 69 centimeters of CSF, but still elevated. And her headache also got better after draining 20 to 25 ml of clear CSF. So the diagnosis of idiopathic intracranial hypertension was finally made. The child was managed symptomatically for her pain with both opioid analgesics as well as paracetamol and other NSAIDs. Anti-edema measures like 3% saline was given initially. The child was also started on oral acetazolamide, and to decrease the CSF production, she was also started on oral furosemide. So a few words about idiopathic intracranial hypertension. So
can we take up few questions here? Maybe few final questions. One is basically you are like your final diagnosis here is idiopathic intracranial hypertension. So what was the therapeutic pathway for this child? What are all the drugs you have given to this child? Only acetazolamide and this thing?
No, sir. Acetazolamide was started later on only. Initially, we gave measures to decrease the ICP.
Okay, raised ICP measures, supportive measures as well, medical measures. Then
the child, then we had the doubt of migraine, and we started the child on triptans, but the child did not improve. And later on, we started this. We did a tapping also again, which drained around 20 to 25 ml of CSF.
No. What I am trying to understand is whether the child received any immunomodulatory medications or not. The child at any point of time, child received steroids, immunoglobulins,
IVIG was
plasma exchange.
IVIG
was,
of these steroids was not given. IVIG was given.
IVIG was given. Okay,
Yes,
okay. And steroids were not given.
No, sir.
Okay, okay. Then what else have been given?
Before you discuss, I want to ask one question to this thing. Is there a possibility that could be changes in the MRI in some areas, it has been described. But here, benign intracranial hypertension, either acute or chronic, may not have that much of changes. Except I want the opinion of the experts.
Sir, just to clarify, Srinath sir, the first MRI report, that was which led us away from idiopathic ICP, because they said that there was some doubtful, suspicious flare changes and very subtle contrast enhancement. They in fact gave more weightage to our clinical inputs, like she has LR palsy and neck stiffness. So with these clinical inputs, they looked at, they reported the subtle findings as very significant. That took us away from initial diagnosis of idiopathic ICP, and then we proceeded towards ruling out infection. But the repeat MRI, which was done around 3-4 days later, that was done because she continued to remain symptomatic with extreme irritability and persisting bradycardia and worsening papilledema. That categorically showed that there was no contrast enhancement at all and no meningeal enhancement as well. And then by then we had also the other series of reports, and then we probably were more sure that this could be idiopathic.
No, maybe the thing is, when we discuss these kind of cases, there are two perspectives to it. One is obviously it's a PG teaching case, so how we present and how we examine these kind of patients. But obviously, this is not like every day we see two patients type of a patient. Everybody will agree with that in that perspective, I think. So that's why few things we may need to discuss regarding how these kind of patients need to be taken care of. Most of the time, why I ask the pertinent question about immunomodulatory therapy is, most of the time there will be a care conundrum in all these patients. So most often we will end up in starting an immunomodulatory therapy, and there will be a therapeutic trial which will be given. I'm not saying that it's right or wrong. So this is the routine pathway, because the natural history of the disease will evolve when the patient is inside the hospital. So this is the common presentation. And another thing what we need to understand is, first MRI to second MRI, we are saying that subtle changes, this has settled. Okay. The other way of putting it is, there are subtle changes and we have done some therapeutic intervention. So there could be a response to therapeutic intervention also. So always we keep our options and thought process open. Whenever you say and conclude, the one-liner is, whenever you conclude a diagnosis of exclusion as your diagnosis, please be extremely cautious, because even you are extremely cautious, 90% time you may be wrong. So that is why you are supposed to be extremely cautious. So because I'm seeing the complete natural history of the disease of the child. The child is having one autoimmune disease 1 year back, requiring therapy, and then it is not completely subsided, presenting with another system involvement. They are not subtle, at least the clinical symptoms are not subtle. There is a lateral rectus palsy, there is a acute raised ICP feature, which may be a subacutely evolving and acutely precipitated, but there is an acute raised ICP feature, to an extent bradycardia, and your opening pressure documentation is 76 millimeters of mercury. There are many clinical characteristics to say that, to put it directly into the basket of diagnosis of exclusion. Okay, so you have to be very careful. Now also you may need to go again and take the history and review and see whether any other thing we are missing. Whether many times what happens, we would have done extensive investigation, T3, T4 we might not have done. We would have done autoimmune panel, just like Dr. Renu told. CSF autoimmune panel would have been done, but the ENA panel or TPO antibody might not have been done. So all these things happens quite commonly. So we may need to keep that also in mind. Mulai, anything more?
Yeah, definitely, sir. Yeah, as said, like we cannot, I mean, ultimately what will happen is we cannot close this patient's case as that we have reached a diagnosis. Obviously, as even many of the seniors in the chat box commented, only the follow-up of child and how she turns out and any new onset of symptoms that are coming up, that will probably make us more wiser in arriving at a proper diagnosis here. And we cannot just shut the doors that this is only this. So that point is really well taken, sir.
And skin is the system. And when you are having, like, obviously the basics are basics. Skin and brain all are ectodermal. Okay, brain is a highly differentiated cell lineage. We can't say that skin and brain are same. Okay, neural cell lineage is highly differentiated cell lineage. That is understandable. But that is also an ectodermal cell. Okay, which is developing into the brain. Whenever you have a skin features, so, and that is the first system of involvement. And whenever the second presentation says there is a CNS involvement, obviously the long-term follow-up becomes a mandate. So what is the disease? Always we won't get the answer. We need not even get the answer. This is like, you are all next generation pediatricians. Most of the questions will remain as question. And time will push you, time will give you the answer. So you have to be very much open-minded while following up this child. That is very, very important. Maybe I feel that is very important. Dr. Renu.
Yeah, so my take on this case is that she has two very important issues to be addressed. First is, typically IIH won't have that kind of vision loss what she had. Typically it is more papilledema and flutters, as well as increased in the size of blind spot and some field restriction. Typically, though, they do not have finger counting kind of vision. So if that has happened, that suggests a kind of very rapid development of papilledema, and she has having ischemia of the optic nerve also, because of the pressure within the optic nerve sheath is very high. So she may be at risk of vision loss very rapidly, maybe within 4 weeks also. That also happens in kids with IIH who develops this kind of a malignant kind of raised ICP. So we have to be very cautious while treating her, and an aggressive therapy of CSF drainage what is required, and acetazolamide and topiramate is usually one we prefer over furosemide. So, and sometime if you see that papilledema is not resolving, they may need surgical interventions also. So this vision issue is a very severe and very important issue in this child. That has to be taken very seriously, because typically we do not see finger counting in children with IIH. Here it suggests a more severe raised ICP and more nerve ischemia is happening. Now the second point is sometime in we discussed most of these cases with our radiologist, and we found there is a stenotic venous channels in these patients, which predispose them to less CSF drainage. That you can also discuss, and sometimes they need shunting also for if the papilledema and vision threatening is there. So definitely these girls need a very diligent follow for her vision basically. And if she's not responding to drugs, then definitely surgical intervention has to be bring in. And regarding diagnosis, I think follow-up, if the symptoms and radiology signs of raised ICP resolves, then the possibility of IIH is there. But if we continue to have new autoimmune symptoms, and then the follow-up definitely needed in this girl. And one more point I want to add, you need to go back to her history of drug. I definitely feel that she has a history of drug intake, which is possibly vitamin A products or some kind of steroids or some minocycline or something has been given. So you have to go back to drug and please check it. You will get this definitely as a correlation that she has developed IIH possibly for 10 months, whatever she has taken. So this scenario we see commonly in girls, in adolescent girls, basically. So these are my takes on this case. Excellently presented and excellently discussed with the team from Dr. Balaji and Sashidharan, and very nice.
Yeah, thank you. I think Traya from PJ Chandigarh, I think Dr. Kandasamy, chairperson, as well as Dr. Renu, as well as Mulai. They've done extremely very well, and as a panelist actually thoroughly discussed case, and our postgraduates also, they presented nicely, Lakshmi, Sasikant, as well as Salima, Kritika. And I invite comments from our the judges, Dr. Ramachandran, PRC sir, Dr. Ramachandran sir.
Thank you. Thanks for a wonderful discussion by the postgraduates. They presented very well the clinical findings, the course, the slides were excellent. So I'm happy that all the other postgraduates, also Salima and the other postgraduate also took part other than Lakshmi. So needless to say that the discussion was excellent by Mullai, Sashi and Renu. All of them from PJ Chandigarh, I presume, some point of time or other, you trained there or worked there. So it was an excellent discussion and very well coordinated and a lot of learning points. So thanks for a very, very patient and elaborate discussion. Thank you.
Thank you, sir. Dr. Ramachandran Mohan, madam.
Yeah, I too thoroughly enjoyed the discussion, the presentation. I think we haven't discussed this case earlier. It was, I mean, they looked at it at different perspectives from a pediatrician, from an intensivist, from a neurologist, and PGs also did excellently well. And we learned a lot in the bargain. Thank you all for the extremely interesting session. Thank you.
Thank you, madam. Dr. Srinivasan sir, please.
Yeah, I agree with all the other judges that it's a wonderful presentation by a very interesting case, and also extremely well discussed by all the three moderators and also Sashidharan with excellent comments. And of course, it's very important that you are training the PGs for the examination as well as a future career. So the time is very important. So they must always try to time it like a swimmer, getting trained. So an examination you get only 45 minutes. So it's not that one day you examine, next day again you go and read, and then again you come. So I wish the postgraduates stick to the time of examination and try to get as much in the history as much in the findings, because it's part of training for your examination. So more time will not be given. So kindly keep it in mind. Thank you so much.
Thank you, sir. Dr. Ramesh, sir, please.
A nice topic chosen because it's not often discussed in the ward clinics or ward discussions. And the combination of faculty was fantastic because the right people discussed it, and it was discussed very exhaustively. All areas were covered. I just want to add one small point. If there were no other signs, only symptoms like diplopia and headache, you would also think of migraine as an important possibility. And as I had mentioned in my chat box, pseudotumor cerebri, like you have in vitamin A hypervitaminosis A, it is common in adolescent girls, pre-adolescent girls, because of the changes in the proposition of the skull and the other skeletal systems, the ocular changes, orbital development. It is one of the differential diagnoses for pseudotumor cerebri, where they also present with features of raised eye strain, and not the least malingering, because some children, especially this, leave alone all those clinical findings and signs, only symptoms, headache and vomiting and diplopia. Then you need to think of conversion reaction also. In my own personal experience, I had a child who had thrown convulsions, very funny type of bizarre movements. And when I'm probing, he was also salivating, and funnily he also passed motion and urine. Then when we probed into the matter, the first doctor also had a suspicion of malingering and conversion, kept on asking whether there was drooling of saliva or deviation of the mouth. So when I went to the next doctor, he started drooling as well as showing deviation, upward gaze and all those things. And that doctor asked whether he passed urine and motion without the involuntary discharge. So when he came to us, he also passed motion and urine. But everything was very, very funny and bizarre. So ultimately, it turned out to be a conversion reaction because all other findings are normal. Just we have to, especially these days, all rare things are also happening. Thank you. Thank you for the opportunity.
Yeah, thank you, sir. Now that concluding remark by Dr. Kamswamy Sasidhar.
Actually, this was a very good opportunity for us to discuss such a. It's a kind of. I won't say that it's an uncommon case, but it's a little bit novice case, and we do not have always a platform to discuss with all the specialty people and multiple viewpoints. So in that way, this PG case discussion was quite useful for everyone, including me. I also learned many things, including when to do autoimmune panel, when not to do CSF autoimmune panel. So everybody had a something to learn. That is the very big advantage of this kind of forum. Thanks to Dr. Rajendran sir and IAP TNSC team for conducting such a wonderful program, and thanks to all the senior judges. So Srinivasan sir, Rama madam, PRC sir, very senior people. They are sitting till 9:30, 10 o'clock, and clearly and watching everything and asking very actively questions. The chat box was full of comments. So this is wonderful. Nothing more to say. I think all PGs, all participants, including the panelists, everybody would have something to learn today extra. So that's the achievement of the day. Thanks to Rajendran sir for such a nice opportunity.
Yeah, thank you, Dr. Sasi. Now I request our guest, Dr. Renu, to comment, please. Final comments. Yeah.
I absolutely enjoyed the case discussion. It's always good to discuss with our colleagues from intensive care. Their perspectives are usually different from us. If I see in OPD, my perspective will be definitely different. If she's admitted in ER setting, definitely the perspectives are different. So it's important to discuss and keep your. I think it's a journey. It's not a diagnosis as one point. Patients keep on evolving, and we also should be keep on thinking about the newer differential diagnosis, and with the more information coming into it, you always become wiser. So it's a great learning, and I've learned from the senior people. Definitely, it's always good to learn from so senior pediatricians from here. Dr. Srinivasan, you've been absolutely wonderful comments from your experience, as well as Dr. Ramesh, very useful remarks. Absolutely loved interaction with Dr. Shashidharan after so many years, as well as Dr. Balaji. I really enjoyed doing my residency with them. So it's been a good experience and wonderful learning case. Definitely learned a lot and enjoyed. Thank you so much for Dr. Balaji for inviting in this session. Thank you so much.
Yeah, thank you. Dr. Mullai, please.
We also enjoyed your comments, especially the drugs is very important, especially Ayurvedic drugs in such a case.
Yeah, so we had a very similar case. She denied absolutely. Father was a sailor and mother was a homemaker in Chandigarh. Very similar presentation, and they came with the nutrition supplement, which has some 4,000 international units of vitamin A, which she was using for a year without thinking any time. And so it's a very common practice in especially if they are in higher socioeconomic status, and they quite commonly use this kind of drugs. We have seen with the topical minocycline, doxycycline used for pimples for months together. So these are the common causes we see in adolescent girls. Obesity, typically obesity is not seen in pediatric
Naldixic acid was very responsible. So many cases of naldixic acid those days are given for dysentery. They used to come with intracranial hypertension.
Okay, and one more point I want to add, adult IIH is, it's more chronic, but pediatric IIH comes quite acutely. So that is a different we have seen. And sometimes we have seen craniosynostosis also with these children with IIH. So some sutural fusion, and they have chronically building pressures with changes in the skull X-ray as well as. So that's also we have seen 7-8 cases with unilateral craniosynostosis presenting with IIH kind of presentation. But I absolutely enjoyed that case discussion today. Thank you so much.
Thank you, Dr. Renu. Dr. Mullai, please. Yeah,
Yes, sir. Thank you for the wonderful opportunity. As we all keep learning, and it is always pleasurable to interact with Dr. Renu ma'am, and of course our ever present, omnipresent seniors, Dr. Srinivasan sir, Rema ma'am, PRC sir, for their words of wisdom. Like always, we learn. It may be a very simple point, but it remains in our mind for years together. And PGs also, they presented well. I think all the 3 PGs participated well, and they answered almost most of the questions. They were all a bit jittery that some pediatric neurologist is going to ask them questions. Then said like it will be all basic only with history and examination, not high funda questions. So I think they also did their part well. And
they did really blinking well. So often. Is it because of that she is blinking so often, the presenter? Because I found she is having so much of blinking.
Okay.
So you have done very well. Yeah. The total team the PGs have done very well, because it's not a very easy case to present also. Obviously, it requires a preparation. They did very
wonderfully done.
Yeah.
Thank Rajendran sir and IAP TNSC team all for this learning opportunity, sir. Thank you, sir. Thank you.
Yeah, thank you, sir. And on behalf of IAP TNSC, I thank Dr. Shashidharan and Renu as well as Dr. Mullai for that wonderful panel discussion. And I thank today's judges, Dr. Srinivasan sir and Dr. P. Ramachandran sir, Dr. Ramachandra Mohan, Dr. Ramesh and Dr. Janani. And I thank all the postgraduates, Dr. Lakshmi as well as Kritika Salima for a wonderful presentation. Once again, I thank all delegates and as well as postgraduates, all India level, they attended today's program. Thank you very much. Thank you.